And welcome to the conceptual basis of urology course. I was actually in an examination with the potential candidates for FCPS Part 2 and noted that people's ability to read an MRI scan for prostate cancer is quite weak. And I think the exposure is very limited. So this is about a week back. And at that point, I decided that I think we need to have a session on prostate cancer and MRI. So we've designed this presentation along with two of my colleagues who are the real expert in MRI scan. And these include Dr. Basit Salam, who is known to all of us, and he has been part of the urology meetings when he was with AKU and then subsequently in the tumor board. And now Dr. Shayan Anwar, who is also part of the tumor board, and her valuable input in understanding the MRI scan during the tumor board meetings. So thank you very much to both of you. And I'm really grateful that you are here this evening.
Thank you for the invitation. It is always my pleasure to be part of the team.
Thank you very much, Dr. Basit. I'm having a little trouble in progressing the slides. So just give me a minute. Right, so these are our two moderators. Both are expert radiologists and have significant experience in reporting prostate cancer. So the key to prostate cancer, understanding the MR of the prostate cancer, is the zonal anatomy. And we know that the three major zones of prostate are the peripheral zone, the transition zone, and the central zone. And in addition, we have fibromuscular stroma. To understand these three zones and to understand the configuration of these three zones in the prostate is key to understanding the MR anatomy and subsequently the pathologies of the prostate. So we're going to talk about these zones, and then we are going to focus on the normal and the abnormal anatomy of prostate on MR. We know that vast majority of prostate cancers, over 70%, originate from the peripheral zone. And the peripheral zone, as the name suggests, is peripheral. As a consequence, it is amenable to digital rectal examination. The other zones of the prostate, like transition zone, houses the other 20-25% cancers, whereas the central zone and fibromuscular stroma are very, very rarely involved with prostate cancer. So in order to understand the MR anatomy, then the anatomy of the zones is extremely important. Now, what you can see here on the screen is the bladder with the white area is the prostate. And through the prostate passes the prostatic urethra. And into the prostatic urethra opens the ejaculatory duct at the point of verumontanum. So this anatomical distribution is well known to most of us. The zonal anatomy is important. So if you look at the periurethral zone, meaning the zone which is around the urethra, we have the transition zone, and that is the zone which is responsible predominantly for the development of BPH. But about 20-25% cancer can also develop in the transition zone. And this zone is periurethral. The central zone is the peri-ejaculatory zone. So it has two components, the two ejaculatory ducts on either side, and it is around those ejaculatory ducts that the central zone, which is predominantly anterior, and this is where your central zone is. The third anatomical entity is not a zone, but it's a small anterior fibromuscular stroma, is a small area of tissue that is situated on the anterior side of the prostate. So as its name suggests that it's anterior, it's fibromuscular stroma. It is hardly ever a site of development of prostate cancer and has very little clinical significance as such. The most important zone from the perspective of the prostate cancer is the peripheral zone. And the peripheral zone is on the periphery posteriorly and laterally. And this is a zone which is very clearly amenable to digital rectal examination. That's why digital rectal examination screening is one of the most important and cost-effective way of diagnosing early prostate cancer. And we know that this is the reason why the prostate cancers are so difficult to diagnose, because they do not have any symptoms. They essentially grow in the peripheral zone, which is not affecting the urethra, so it has very little symptoms. So most of the time, the symptoms are that of BPH, and this is how most of these people present. So we'll share a little video clip showing the same anatomy. So you have seminal vesicles from which the ejaculatory duct arise and they open into the urethra at the level of the verumontanum. This is the prostatic urethra, and around the prostatic urethra is the transition zone or transitional zone. And this is responsible for the development of BPH. You have the central zone, which is around the ejaculatory ducts. Then we have the peripheral zone, which is a posterior lateral zone. And this is the place where majority of the prostate cancer develop. The anterior fibromuscular stroma is lying anterior to the central zone. So you can divide prostate into anterior and posterior parts. You can divide the prostate into base, which is close to the bladder, the mid zone, and the apex. And each part is then subdivided into various subzones. And as you can see, that prostate is not a geometrical structure. So the representation of various zones in the base, mid zone, and apex is unequal. So some parts has greater part of peripheral zone, some part has greater part of the other zones. So this is an important point to remember. Now, MR anatomy of the prostate is really understanding the zonal anatomy. The peripheral zone is a thin layer of homogeneous high signal intensity with a hypointense, well-defined and non-interrupted or continuous capsule. So understanding and identifying that capsule is extremely important, as we know that as urologists, it's important for us to define whether there is any penetration of the capsule, because capsular breach or is extra prostatic disease, and often these patients are not amenable to radical prostatectomy. The transition zone typically shows heterogeneity of intermediate signal intensity, focally replaced by well-circumscribed hyperplastic nodules of BPH. Now, don't mix them with the nodular prostate of prostate cancer, because these nodules are in the transition zone and they have nothing to do with prostate cancer. The seminal vesicle have a uniform high T2 intensity, and typically there is no lymphadenopathy. Okay, so these are important consideration, and this is important for you to understand the MR anatomy. I would now request Dr. Shayan Anwar to talk about MR sequences and acquisition. Dr. Shayan.
Assalamu alaikum everyone. Good evening, and thank you, Dr. Hamad, for having me on board for this lecture. Can we move on to the next slide?
Yes.
Okay, before getting an MR done, what is most important is to have a good magnetic field strength. And in that case, a 3 Tesla MRI is preferred over 1.5 Tesla, and definitely nothing beneath that. So the point is to have a good spatial resolution and a very good DWI sequence acquisitions and dynamic sequences, so that we can come to a conclusion whenever we are reporting any knife patient and we have to establish a PIRATS category. So the gradient strength is very important to have a very good image quality in cases of diffusion weighted acquisition. And for that purpose, we can use a body phased array coil or a spine coil. An endorectal coil is not necessary for this examination. As far as patient preparation is concerned, there should not be any MRI related contraindications that may include any metallic implants, foreign bodies, any unconditional pacemakers, or poor renal function, or even severe claustrophobia. So after checking on that, we can have administration of antispasmolytic agents, which has been proposed in literature. But if it is contraindicated, then we can go ahead with examination without administrating any antispasmolytic. These may include hyoscine, or including buscopan or glucagon. And this is basically used to reduce motility of the Barber loop and reduce motion artifact. Fasting is not necessary in this examination, and ideally we should have a clear fluid diet a night before the examination, followed by a rectal enema, but at times it is cumbersome. So the recent literature proposes that a micro enema of 5 ml laxative is given 15 minutes prior to the examination to clear the rectum of the feces. And this can be followed by a rectal catheter just to exclude any gas within the rectum, which might be distended and may cause a lot of artifact during acquisition. The patient is also asked to refrain from ejaculation at least 3 days prior to the MR examination. The purpose is that to have a very good volume of seminal vesicles, so that we can, really assess any invasion of the seminal vesicles. And other pathophysiology which they have proposed is that the intrinsic diffusion and T2 bright signals of the peripheral zone might be compromised due to ejaculation. So that's why it is asked to refrain. So moving on our next slide. The acquisition protocol, when we're talking about the acquisition protocol, the most important is a T2 weighted sequence. The PIRATS category needs at least 3 important sequences, that is T2 weighted, diffusion weighted, and dynamic contrast enhanced. So to acquire a T2 weighted sequence, we should have a good axial plane, and for that purpose, it should be along the long axis of the prostate gland. We can draw a line between the interface of prostate and rectum on a sagittal sequence, and then have a perpendicular axial image through that plane. So this is an orthogonal plane, and similarly, a coronal plane is also orthogonal to the sagittal plane. After acquiring these 3 sequences, we can move on to DWI sequences, the diffusion weighted sequences, in which we can apply a shim box Shrimbox is a special software which we can apply to improve homogeneity of the magnetic strength so that there are no artifacts. And this is it's ideal to have a high V value of around 1400 seconds per millimeter square. In our department, we are still doing 800, but we are trying to improve on that. Then moving on to dynamic contrast enhanced MRI, this acquisition is done in axial plane and it is in the same position and phase encoding direction as that of T2 and DWI sequences. And this is acquired before, during, and after injection of gadolinium contrast at a temporal resolution of less than 15 millimeters per 15 seconds for at least 2 minutes. And a delayed axial image is also acquired to look at the pelvic lymph nodes as well. And for this purpose, of course, a trained technologist, radiographer is recommended, which is not always available. Okay, can we move on? Next.
Yeah, sorry. Okay. My apologies. Somehow the animations are.
You just need to click. I think it will show on. So, okay, I can tell you this is the entire list as I have already explained. This is the systematic way we go on. And the last one is one larger FOV to aortic bifurcation. So in our department, we perform a large field of view coronal T1 sequence to look at the para-aortic lymph nodes. So this is also an additional sequence and every institution has their own protocols. Next. All right, so in this, we can see that on the top left, this is an axial T2 weighted sequence. How to recognize a T2 weighted sequence? You will see bright signals within the urinary bladder. On the right, you have a sagittal T2 sequence. Again, you have bright signals within the urinary bladder. This is how you identify a T2 weighted sequence. On the lower left corner, this is T2 coronal sequence. So these are all orthogonal planes and fast and echo sequences. And then the smaller image is a T1 weighted axial sequence, and you see very low signal within the urinary bladder. So this is indicative of a T1 weighted sequence. This is mostly acquired to assess any hemorrhage within the prostatic parenchyma. Next slide.
Sorry.
All right, so on the top left, this is a DWI and ADC. And the left one is a DWI sequence in which we can see bright signals within the prostate, and on the right is the corresponding ADC mapping. Here we can also calculate the ADC value of the lesion, and if it is less than 600 millimeters per square, then it is definitely significant. Lower left, this is dynamic contrast enhanced acquisition, which is acquired on a fat suppressed T1 weighted sequence. It is dynamic and acquired in an axial plane. And on the right, we have a larger FOV T1 weighted sequence.
Thank you very much. Yeah, thank you very much, Dr. Shayan. I think it is quite clear. It's a very technically demanding imaging which require input not only from the radiographer, but also radiologist during the process of doing it. And even small little missing a small details can actually result in distortion and may affect the quality of image. And as a consequence, it's important that the MRIs are done following all that what is described by Dr. Shayan. Basit, you want to add something in the acquisition before we move on to the normal MR anatomy?
No, I think she has defined everything very well, and I hope participants have some basic understanding about how they appear on MR.
Okay, so I would like you to focus on this picture on the left-hand side, and we have described the zonal anatomy. We have described the anatomy of the prostate in various, the base, the mid-zone, and the apex. And we know that because of the configuration of prostate is such, at different levels, different zones are differentially represented. So I'm going to share a few slides of the normal anatomy of the prostate on MR so that Dr. Basit and Dr. Shayan can take you through some of the abnormalities and how to identify these abnormalities. So it's important that one must understand the normal anatomy. So now in this section, we are actually at this level. Is my arrow visible?
Yes.
Yes.
Okay, great. So follow this star and we're going to look at the various anatomical structures. You can see urethra here, the rectum here, and this is the pubic symphysis. So we are really very lower down. And now we move on. And as we move on, we can see the various, the zonal details of the zonal anatomy of the prostate. The urethra is still visible at this point. Now, at this point, you can see most of the prostate, and clearly you have the transition zone here. This is the pink area is marked by the peripheral zone, and we are slightly higher up in the prostate where we can see the anterior fibromuscular stroma. We can see the transition zone, and we can see the peripheral zone. The rectum is down here. This is the capsule of the prostate, and this is very important to understand because there should not be any breach of the capsule of the prostate. And as you can see that this is the BPH nodules, this is enlarged transition zone, and we have the peripheral zone here, and you can see that the intensity of the peripheral zone is very different from that of the transition zone, and the capsule marks the periphery of the peripheral zone. And this is the transition zone, which is where your BPH develops. And these are the nodules of the BPH, which are in the transition zone, and do not confuse them with the nodules that you see in the peripheral zones, which are indicative of prostate cancer. Now, this is another important anatomical structure. Once you have identified the peripheral zone, you've identified the capsule of the prostate. The neurovascular bundles are really here at 5 and 7 o'clock position, as you see in the during the radical prostatectomy as well, that this is the location of the neurovascular bundle. Now, once our expert radiologist will share various pathologies of the prostate cancer, you will be able to see how the neurovascular bundles are identified in abnormal MR images, and how their involvement is diagnosed. This is a question that we often ask our colleagues during the tumor board meetings, whether the neurovascular bundles are involved in order to make a decision whether they can be spared or not. So these are your neurovascular bundle. You start seeing the bladder here and the rectum with levator ani muscles lower down. Now this is really high up, and with your bladder, which is appearing thick walled, but it's because that it is an almost empty bladder. The seminal vesicles are visible here, and as explained, that slightly distended seminal vesicles are preferred because you can then be able to comment on the involvement of the seminal vesicles clearly. So these are various anatomical things which are in the normal prostate. And from now on, if there are any questions, or if either of our panelists, Dr. Shayan and Dr. Basit, would like to add anything before we move on to the abnormal MR scans.
I think we can move on.
Yeah, you can move on.
Okay. You guys, most of you know that we have PIRADE scale or grading system, and it's extremely important to understand the PIRADE, which often urology colleagues have difficulty in understanding and categorizing your patient on various PIRADE categories. It's important to know what T2 weighted BC and the ADC map images, corresponding images are showing to make a diagnosis of what PIRADE grade this is, how it is diagnosed. So it's the most important component of today's talk, and Dr. Basir Salam is going to take you through the PIRADE grading system and how PIRADE grading is done. We'll give you examples subsequently as well. So Dr. Basit, over to you.
Thank you, Dr. Hamad, and Assalamu alaikum, everyone. So a little brief introduction about the PIRADES. Basically, PIRADE is a prostate imaging reporting and data system, which is basically a structured reporting scheme to report multi-parametric MR for the evaluation of suspected prostate cancer, and it has a score starting from 1 to 5, and category 5 is highly has the highest probability of prostatic cancer versus category 1, which it is categorized as normal scan. And as it has been explained, that it involves combination of imaging findings, which is based on T2 weighted image, the DWI and ADC sequence, and the dynamic contrast enhanced sequences. PIRADES basically gets updated since it was started, and the recent version that is in practice these days is PIRADE version 2.1, which was last updated in 2019. And since then, it is being used globally, and it is developed by a joint group between the American College of Radiologists and the European Society of Uroradiology and AdMeditech Foundation. So just to simplify PIRADE, as Dr. Hamad and Dr. Shayan have already described the peripheral zones and the transitional zones, the application of PIRADE in transition zone and peripheral zone slightly differs. Let me just brief you about the peripheral zone PIRADE application first, and then I will talk about the transitional zone. So for PIRADE zone, if we see, as Dr. Hamad has shown, the peripheral zone, if it is completely appearing hyper intense, which is uniform, then we call this as normal prostate. And for simplification, the peripheral zone, we apply PIRADE on DWI and AD sequence, and for transitional zone, we rely on T2 weighted sequences. So the predominant sequence for transitional zone is, or the dominant sequence, you can say, for transitional zone is T2 versus for the peripheral zone, which is DWI and ADC. And subsequently, if we see that the peripheral zone is homogeneous and high signal intensity, that means it is normal. If we see some linear or wedge shape hypointensity or diffuse hypointensity with indistinct margins, that is not what we see in category 1, then we describe this at category 2. I'm only and only describing the DWI appearance of PIRADES on peripheral zone. Remember, I will talk about the transitional zone, because transitional zone is slightly different for application of PIRADES. And for intermediate lesions, which are categorized as PIRADE category 3, we see that the signal intensity becomes heterogeneous, and the lesions that we see are non-circumscribed. They may be rounded and may show moderate hypointensity, and they do not qualify as the other thing that we exclude, that they are not falling in category 2, category 4, or category 5. Then we label them as pyrette category 3. And pyrette category 3 can further be decided with the help of dynamic contrast enhance. Either it is category 3, which is equivocal, versus category 4, which has a high probability of cancer. And for pyrette category 4, if the lesion is markedly hypointense on ADC mapping, that is, it is appearing very black or more towards blackish appearance on the ADC sequence, and is bright, that is appearing white on DWI, then we call it as pyrette category 4 lesion. Pyrette category 5 lesion has the same imaging appearance as category 4. Only difference between category 5 and category 4 is the size of the lesion. If the size of the lesion is 15 millimeter or less, then it is characterized as pyrette category 4. And if the lesion is 15 millimeter or more than 15 millimeter, then it is categorized as category 5 or pyrette category 5 lesion. So this is the description of peripheral zone lesion on DWI and ADC sequence, which are the dominant sequence to evaluate peripheral zone lesions. And when I just, as I said, that pyrette category 3 lesions should further be classified. Either they are 3 or they can fall into category 5. For those lesions, we see these lesions in dynamic contrast enhanced sequence, which will show early enhancement if it is a suspicious lesion with when compared to rest of the prostate gland. If there is early focal enhancement, then we will call this as category 5 lesion. If there is no enhancement, then it will stay in category 3 lesion. Dr. Hamad, I think screen I don't see now. Your screen. Are you guys with me?
Yes, sir.
So meanwhile, when the okay, and as Dr. Shayan has said, that we mostly rely on ADC because when we do the imaging, we do the DWI sequence with low and high B value. So if the B value, high B value imaging is corresponding with the ADC and T2 abnormalities, that particular lesion is to be considered highly suspicious and has to be characterized either category 4 or 5, depending on other parameters that I described, which is the size. And thank you. Now I can see the screen. For the transitional zone, because there are changes, mostly we see changes that are associated with benign prostatic hypertrophy. So transitional zone lesions are really challenging to be characterized on dynamic contrast enhanced sequences. For that reason, T2 weighted sequence is the predominant or the dominant sequence for characterizing lesions that are seen in the transitional zone. And we the changes of BPH are usually nodular, which usually have encapsulated margins with some hyper intense areas, which are referred to as cystic changes, that we can see on our screen on the right side in the topmost image. And if this appearance for transitional zone is going to be characterized as or given a score of 1, and two, these for pyrite 2 or giving a score of 2, these lesions may not show a typical encapsulation, or they appear as atypical nodule, which may have mild hypointense areas within or between the nodules. So they sometimes create confusion, but other sequences will be not showing abnormality. So that is one thing reassuring, especially the DWI and the AD sequence. For any abnormality to be present, it has to be reproducible on all the sequences in the same location to be called as abnormal. This is the most important thing. For category 3 lesions, we expect some heterogeneity in the transitional zone, and of course, like for the peripheral zone, we can definitely apply the rule of exclusion that they do not fall in category 2, do not fall in category 4 or 5. So we can classify as them as category 3 lesions, or the score of 3. And usually they appear heterogeneous, and margins sometimes can be obscured, and like I said, they do not qualify for category 2, 4 or 5 lesions. And for category 4 lesions, which we are interested, because the chances of malignancy are high in this, they usually have rounded oval or lenticular shape when non-circumscribed appearance. They will show hypointensity, which is going to be more intense, like more towards the blacker shade, and the size for category 4 lesion is again less than 15 millimeter. For category 5, the same findings, like moderately or markedly hypointense appearance of the lesion, and the size being greater than or equal to 15 millimeter. And if we see extra prostatic extension in the form of capsular breach or anything like that, then of course it is a pyrite 5 category in the transition zone as well. And for like I said, for characterizing lesions which are like in the gray zone, that especially category 3, like I described for category for the peripheral zone, we have to rely on the dynamic contrast enhanced sequence. If the contrast enhancement is focal and intense, then we will add one more score to the category. That means from category 3 to category 4 for the peripheral zone. But the enhancement of benign prostatic hyperplasia are very difficult to be differentiated from the cancer enhancement in transitional zone. Therefore, we rely on DWI sequence after evaluating the transitional zone lesion on T2 weighted sequences. And for evaluating the for further evaluating the transitional zone sequence, we will see whether there is any abnormality seen on the ADC or high B value DWI sequence. If there is no abnormality, then only one score is given, and then we doesn't need to be worried that this may be possible malignancy. If the shape is linear or wedge shape, even though it is hypodense but not very hypointense, then on ADC or DWI, then still the score is 2, because lesions which are the shape is equally important for the lesions. If it is wedge shape or linear, then the index of suspicion should not be very high, and the score is 2. provided they are not very hypo-intense on ADC and hyper-intense on DWI. They are subtle like. And for categorizing transitional zone lesion on DWI, for giving a score of 3, we should see a focal or discrete lesion which is moderately hypo-intense on ADC and showing corresponding hyperintensity on high B value DWI sequences. So they are characterized or given a score of 3. Based then we will revert to T2, and if it is equally suspicion on T2, then we will categorize it by combining these two scores. For giving a score of 4 in transitional zone on DWI, the abnormality has to be focal and markedly hypo-intense. The hypo-intensity that is easy for you guys to understand, that you should see the surrounding muscles, their appearance is very black. So that black appearance you have to match that appearance with the appearance of the lesion to characterize that lesion as markedly hypo-intense. If it is matching, then you just label it as markedly hypo-intense. And again, the criteria for category 4 and 5 is again the size, which if it is less than 15 millimeter, then 4. If it is greater than 15 or equal to 15, then it is category 5. So just a sum up that for peripheral zone, DWI is the dominant sequence. For transitional zone, T2 is the dominant sequence, but doesn't mean that we do not see other sequences, but dominant sequences that, and then you have to correlate the findings that you see on these sequences with additional sequences as I have described. And for transitional zone, the dynamic contrast enhance creates sometimes problem for the interpreter to apply pyretes. I hope I have clarified this to a certain extent for you guys to understand.
Thank you very much, Basit. I think this is technically very demanding, but for urologist and urological trainee, some of these things are difficult to follow. But this presentation is recorded and it will be available on the PAUS Karachi website from probably over the weekend. Sharif will make sure that these are available, and you guys can see that and go through this again at your own leisure. So we'll now take some cases, and we'll seek input from our panelists about what are the possible things seeing in these cases. So this is a 56-year-old male who presented with moderate lower urinary tract symptoms, and his digital rectal examination essentially showed a clinically T0 disease. However, his PSA was high, it was 13. Transrectal ultrasound showed that he had a prostate of about 220 cc, which is really large. However, his PSA density is 0.06. So essentially, this PSA density is indicative of benign pathology. However, because of the raised PSA, he was advised to undergo MR scan, and Dr. Basit is going to just comment on this MR scan. So please write down on your chat box if A, B, C, D, E, or F is axial section, a coronal section, or a sagittal section, and what do you think is the sequence? So while Dr. Basit will explain these images.
Sir, I will take up this case.
Okay, please go ahead.
All right. So on the top left, like A image is Oh, should I explain or what?
Yes, yes,
Because,
please.
all right.
Hmm.
So this is an axial sequence T2 weighted in which we can see very smooth, homogeneous T2 hyperintense signals in the peripheral zone. And while the transitional zone appears enlarged and heterogeneous, and we see multiple typical nodules within it. And these nodules have a definite hyperintense rim around them. It means they are well encapsulated. And in the B image is the ADC image, while C image is the DWI image, in which we can see some indistinct hyper intense signals on DWI, which are showing some corresponding dropout or black signals on ADC. But again, these are very indistinct and ill-defined and linear. Coming to D image, this is a dynamic contrast enhanced sequence in which we can see some patchy enhancement or popcorn-like enhancement of the transitional zone. We did not see any definite discrete enhancing focus over here. And on the E image, we can see that there is significant enlargement of the median lobe, which is protruding or indenting the base of the urinary bladder. So there is definite enlargement of the prostate gland in the central and transitional zone. And again, the last image is a coronal T2-8 sequence redemonstrating multiple typical nodules within the prostatic parenchyma with intact prostate capsule. So overall, this is a PIRAD 1 category indicating benign prostatic hypertrophy. We do not see any suspicious lesion over here.
Thank you very much. Let's move on to the next case. So you see that a very raised PSA of 13. However, the PSA density and subsequently the MR showed that it is only because of the bulk of the prostate and the volume of the prostate rather than the cancer itself. So this is a 61-year-old male with recurrent significant urinary tract symptoms. They were mostly storage symptoms and they've been there for many years. In fact, he says that he had it during the earlier years of his life as an adult, and they were quiet for some time and now they have reappeared. His digital rectal examination was unremarkable, so there was no palpable lesion on DRE. His PSA was 5.1, and for a 61-year-old, it is just about significant. The truss volume is 63 cc, and his PSA density is 0.08. So it's really to the point where at 0.08, the chances of cancers are low, but because of his PSA at 5.1, an MRI scan was done, and Dr. Shayan is going to take you through these MR pictures, selected pictures of this MR scan. So, Dr. Shayan.
I think this is a previous
Oh,
case.
this is, sorry, I beg your pardon. This is the one.
All right. So on these images, in picture A, we can see that as marked by the circle, there is a wedge-shaped linear area of hypointensity in the peripheral zone on the right side. And if you look at image E, it appears very linear as marked by the circle. And on image F, the coronal, again, it is very linear and indistinct, and it is hypointense, but not as hypointense compared to the transitional zone parenchyma. So it is a relatively low hypointensity. And if you look at image C, which is the DWI, we do not see any bright signals over here. It appears very homogeneous, the entire prostate gland. And again, on corresponding ADC, that is picture B, we see very subtle hyperintensity. It is not that low, and it is very indistinct as well. Though on contrast enhanced sequence, that is image D, there is on the lower left, we see that some enhancement is there, which is again very indistinct. So overall, considering a peripheral zone lesion, we should be looking at the DWI sequences, we do not see any significant diffusion restriction in this area, though we see some contrast enhancement because the modifier for peripheral zone lesion is a dynamic contrast enhanced sequence. Then considering these two scores, it is a pyrite 2 lesion indicating infection. So we do not see any suspicious area over here.
So I think this is extremely important because you really need to be good in differentiating between prostatitis and prostate cancer. So his PSA in both the conditions, the PSA would be raised. They can even be suspicious digital rectal examination. And sometimes if the MRI are not read properly, you can actually misdiagnose a prostatitis as prostatic malignancy. So thank you very much, Dr. Shayan, for this very nice description of differentiating between prostate cancer and prostatitis. So we move on to the next case. 70-year-old male who has had a rectal examination which showed no nodular thing or non-suspicious prostate. His PSA was 9.8. He has got a big prostate of about 115 cc, and his PSA density is 0.08. So this patient, again, we did a MRI scan, and Dr. Basit is going to take us through this MR scan.
Yes, thank you, Dr. Ahmad. So again, we see different sequences. A is the T2 axial sequence followed by the ADC, which is B, and this image number C is the diffusion weighted sequences. We definitely see an abnormality which is marked with the circle. It is appearing moderately hypointense if you are going to compare, but the hypointensity is not extremely or very markedly hypointense. If you compare this hypointensity with the capsule rim appearing more hyperintense, and if we look at the DWI, the image number C, it is appearing bright, but on ADC the hypointensity is there but not very marked. So this was a questionable lesion, like I said, to be categorized in category 3. But further, we take the help of dynamic contrast enhanced sequence, which is the image number D. We see a focal intense bright enhancing area which is corresponding with the abnormality that we were able to see on image A, B, and C. So based on this enhancement, we will award one more score for this lesion from category 3 to pyrite category 4, making it highly suspicious for a possibility of cancer. And we can see that this lesion is seen to be abutting with the capsule. So whenever some lesion abuts with the capsule, we have to be very cautious in seeing. But if you look carefully on the image number C, we still see a hyperintense rim. This is definitely characterized as category 4 lesion because the size, I presume, is I cannot take the size, but it is less than 15 millimeter. So this is category 5 from category 4 from category 3 to 4 make with the help of contrast enhanced sequence. Yes, Dr. Ammar.
Okay, thank you. Now, I think this is one of those cases in which we have very subtle MR changes. And these are patients who are well suited for truss MR fusion biopsy. And this patient had MR transfusion biopsy. And this is one of the cases that was actually taken from the European Urology publication. And this patient had an ICUP grade 4 cancer, which obviously is a high-risk prostate cancer. So we move on to another case. This is a 74-year-old male who has had a rectal examination which was suspicious on the right side, and the clinical stage was T2. His PSA was 7, and his stress volume was 64 cc, and his PSA density is high now. So between 0.8 and 0.15 is still sort of a gray zone, although if it is crossing 0.08, you can suspect that there may be low-risk cancer or intermediate-risk cancer. If it crosses 0.15, then there is a chances of up to 0.2, you can actually think in terms of disease which is with capsular penetration. So this patient again had an MRI, and this is the MR sequence that you are seeing. And I think Dr.
This is my case.
Basit, yes, Dr. Basit has described this case.
Yes. So, so again, if we start looking from, but this is the peripheral zone. So as I said, for peripheral zone, we have to rely on DWI and ADC sequence. And if we see the images C and B, on image C, this abnormality within this oval circle is very bright or hyper intense, and on corresponding ADC mapping, this is appearing as markedly hypo intense. That is, it is very, very black. And we can also see the same abnormality on the T2 weighted sequence, which is in image number A. And if we see the contralateral side, we can see the capsular margin very well seen, but as shown by these arrows, we can see the irregularity around the capsular margins, which is very suspicious for capsular breach. This lesion definitely looks bigger in size, most likely bigger than 15 millimeters. So this lesion has to be characterized based on the 3 sequences that I have described as category 5 lesion. And we further look on the inferior images. In image D, we can see on dynamic contrast enhancement, there is enhancement which is corresponding to the abnormality that we have seen in the DWI, ADC, and T2 weighted sequences. Number E is the sagittal weighted sequence, and number F is the coronal weighted sequence of the same abnormality, where we see that there is capsular bulge. So there is a high probability of extension into the beyond the capsule, which is considered as extra prostatic extension. And for every extra prostatic extension, the lesion has to be characterized as pyrette category 5 lesion. Thank you, Dr. Amar.
Thank you.
So again, the next case that we see is we see if we look at the bottom 2 images, which are the DWI and the ADC. On ADC, this lesion, which is seen on the right side, shown by the arrow, is markedly hypointense and showing corresponding hyperintensity on DWI sequence and appearing hypointense on T2 weighted sequences. The size of this lesion, as shown, is 16 millimeter. So this is category 5 lesion based on the PIRED criteria, and we see that this lesion can be characterized on this T2 and corresponding ADC and DWI sequences, and we do not need additional contrast to prove this. Yes, Dr. Mark.
Okay, so this patient was biopsied and he had a Gleason 3+4, which is intermediate risk prostate cancer. And there was no extracapsular extension. So options of management were discussed, and this patient actually underwent radiation therapy with hormones. Okay, now I have a question for the audience. We have crossed our 1 hour thing. We still have quite a bit to cover. So what do the audience suggest? I think we cannot complete this course in the next even half an hour. So we need at least 35 to 40 minutes to complete. Do you want this course to go on to the next Saturday? So please give an opinion and then we'll take a decision about what to do, because we need at least one more 35 to 40 minutes to complete. So I think majority of those who have expressed they want this to continue for next Saturday. And I have to seek input from my two esteemed radiology colleagues if they are happy to conduct this further and take it to completion in the 2 weeks from now.
All right. I think after 15 days, right?
Yeah, yeah.
Yes, inshallah. I will hopefully, because it's going to be October. So
It will
I
be
hope
the first Saturday of October. So
that-
what we will do is that I think I'm really giving you a short notice, but you can check your calendars, see your engagements, and maybe confirm in the next 4 or 5 days. So we can organize this on the first Saturday of October to take it from this point onwards and discuss these interesting cases, because I think the application of what we have learned in terms of zonal anatomy and the MR normal anatomy, and then Dr. Shayan and Dr. Basit have taken us through some of these MR images, which are very representative images taken from the expert cases. And we will be taking this session to completion so that you can apply all that knowledge. In the meantime, I think you can watch this 1 hour session again on the Karachi Urology, Paus Karachi Urology website, and come afresh 2 weeks from now to see all those cases and maybe give input on your cases as well. Okay, so thank you very much for being here this evening. And I'm particularly thankful to our two radiology panelists for their valuable input, and hope to see you all on the first Saturday of October, again at 8 p.m. So have a very good evening.
Thank you so much. Thank you,
Thank you.
everyone.
Thank you. So, thank you. Inshallah.